I'd been in hospital 3 times in 12 months or something like that, and that put me down as a suitable candidate. Because the idea with the virtual ward is, you see, that they give you help and look after you so that you don't go into hospital.
Well, I think it's a very good scheme because it takes a lot of the worry off us and it keeps him checked up all the time. He's in good hands, so that's it.
Is that a rash down that arm, or it shouldn't be?
Since we've had the virtual ward team, we get more attention quickly.
He said, would I like to try it? And I said yes. And I'm glad I did, because I was always in hospital and I don't have to go so much now.
Most people, if you ask them, that are living with a long-term condition, a hospital stay is something they try to avoid.
What citizens want is to live with independence and dignity in their own homes for as long as they possibly can. And to do that, we need a system that works in a very different way to the one that we have now.
The virtual ward service model involves stratifying patients according to their predicted risk of hospital admission, and having identified the patients, you then care for them using the principles of a hospital ward, but in the patient's own home, in the community setting.
Traditionally, many acute hospital admissions are simply because a breakdown of either social care or simple procedures such as medication monitoring or blood tests can't really be done easily and in a short timescale in the community. So the virtual ward is this ward of potentially unstable and vulnerable patients who we're providing a higher level of medical care to, but without needing to be in hospital.
The virtual ward looks after patients with multiple comorbidities. The top 5 really that we're targeting are asthma, coronary heart disease, heart failure, diabetes and COPD. But of course they very often have a combination or many more.
The whole point of the virtual ward is to give patients more time to educate themselves about their disease, to help them manage their own condition, to feel more confident about dealing with their illness.
They can give us instructions, like, you know, how to manage the condition, yes. The virtual ward team are very good at that.
2 or 3 years ago, if somebody had told me my potassium levels were no good, I mean, it wouldn't have meant anything to me. But Hannah has explained to me now that if I've got potassium levels that are wrong, it can lead to a heart attack, which could be fatal.
By the time people go into hospital, majority of the time, they're already quite acutely ill, whereas we're trying to educate and prevent by getting people to understand their symptoms a lot earlier and to actually initiate treatment a lot earlier.
We'll increase the diuretics.
Oh, well done. Yeah, you tell me then.
For everybody, the virtual ward actually it's a win-win situation. The patient gets to stay at home, which they want to do. We get to not have to pay a bill for a hospital, which we don't want to have to do. It works well for everybody. Warwickshire has a population that is ageing, as all populations are, but ours is ageing slightly faster than other people's because people come to Warwickshire to retire. One of the first things that had to help us look at was a significant recurrent financial problem that we had. And a lot of that was deriving from the fact that we overused our hospital system, so we needed to find a different way to operate. And our primary focus is to build a health system that faces towards the community rather than towards the hospital.
We were writing a long-term conditions strategy in Warwickshire and were looking at best practice, and we came across a model of care in Croydon that was called virtual ward and thought that it was interesting and worth having a look at.
NHS Warwickshire was clear that it wanted to shift resource from the acute sector into the primary sector and was also facing a financial deficit, and that was the context in which the Financial Recovery Board was set up and the virtual ward project emerged.
The key risk for us, I think, was first of all around getting GP engagement. The next risk is around getting some confidence in the patients so they feel comfortable to manage in this way. And the third thing that we had to do was to make sure we had enough community staff who were sufficiently confident to manage patients with these kinds of degrees of illness, which perhaps was a bit more than they were used to, and a slightly different approach. And all of those elements had to be lined up if it was going to work.
It was a new way of working. You know, we have always been a very reactive service in community nursing, and this way we could actually find patients before they actually needed us. Any pains in the calf at all?
We found that there were 62 patients who generated 620 emergency admissions that cost 1.3 million. And that in itself was really powerful. If we target those people, we can make a big impact on the way in which we spend money.
Time after time we've done surveys in hospitals, and we've found that 20%, 30%, 40% of the patients who are in there wouldn't need to be in there if there was somewhere else they could be. And the virtual ward is for us one of those places that's somewhere else they could be.
Jolly good. All right. See you both in a week's time. Bye.
Risk stratification is about identifying levels of risk within our population. The risk being how much inpatient, outpatient and A&E activity they may have in the next 12 months and the cost impact that that might have. And overall, this top 5% are actually consuming nearly 75% of all our emergency bed days.
This is actually based partly on admissions data and data from hospitals, but also the advantage of the system is that it uses GP data on chronic disease management and also QOF data, so that we get a genuine reflection of the most complex and risky patients in terms of hospital admission.
And therefore you can target your resources, your nursing staff, on people who are going to benefit the most from it.
And this is why we're using this group of individuals to target for our virtual ward. Engaging with the GPs was a vital part of getting this project up and running. Had to approach 75 practices in Warwickshire to gain their consent to extract the data from their systems.
There were some initial concerns from GPs. Confidentiality issues were worked out by the PCT IT department in conjunction with the local LMC. And in a sense, the data being used is in parallel with the data that we might share with our community teams, for example, relating to palliative care. There were other concerns about an increase in GP workload and visits. But again, overall, the actual workload for primary care, in our experience, has been neutral. Many patients who we were visiting for crisis management and recurrent admissions are now far more stable and actually require very few visits from their GP.
For the future for risk stratification, we're in the process of trying to roll that out in two areas. One is into commissioning, so in the way that we commission healthcare services and embedding that tool as part of a process of identifying the right needs and putting basically the right resources where the needs are for our community.
I think the other future area where risk stratification software will be important will be in the development of community services and the more appropriate use of services that already exist, particularly with limited resources.
To get the pilot up and running, there were lots of things we had to do. Just a few of those things would be some of the processes, some of the pathways, the IT, and things such as the risk stratification tool, and of course staff. So there was a huge amount of groundwork operationally to do before we could even get ready to actually see any patients.
We decided that we wanted to look around in the market for who would be the best provider of the pilot service. In the end, we decided that the best combination would be our own community service provider working with healthcare at home. And the reason we did that was because we knew that healthcare at home had experience of managing patients who were quite poorly in the community.
I think we were able to take some pressure off operations and provider services by really bridging the gap between the vision of the commissioners and the practical reality of trying to deliver a service in the community which we understand.
How are you today? It's always a challenge to work with other organisations, and quite a big challenge was working with social services, and I think there is a lot more work to do in trying to integrate social services and still the neighbourhood nursing teams and the virtual ward.
The stakeholder engagement was extensive, and that's always one of the challenges in service redesign, to try and communicate the principles as well as the future operating practice for a service and get everybody on board. So negotiating around those service levels was part of what took the time.
The challenges of working across agency were very much about trying to develop trust so that everybody understood what we were trying to achieve, understood the role that they had to play in it, and felt that they could rely on their colleagues to support them.
There was a lot of interest, scepticism, possible feeling threatened by what would it mean to them? Is it extra work? What skills are they going to need to gain as well? I think over time, though, that has changed, and there is much more integrated working, shared practices, shared meetings. So we have moved a long way in a very short space of time.
So they're starting to look at the pathways actually going through that. It's about building up this team that everyone's got their own little skills, and we can just make sure we all interlink, and it's not about everyone knowing everything, it's everyone just having a little bit, and hopefully we can build that and make that best for the patient then.
The biggest advantage of all is that, to be honest, we now work as a very, very close team with the virtual ward, and we feel that they're an integral part of our primary care team.
Good to see you. Thanks a lot. As part of our management of the financial issues that we had last year, we put in place a financial recovery board, and we went through a whole range of projects that we had in place that we were reviewing and seeing the impact they had in terms of improving things.
It came back before the financial recovery board on several occasions before we were prepared to press the button and roll it out. And I think that was particularly around evidence that it was going to deliver the financial savings that we were looking for, and evidence that we had sufficient staff with the right skills and training to industrialise it and roll it out.
We had a non-executive director who'd got strong business skills, strong financial skills, and he was able to challenge, to be a critical friend in a way that we probably couldn't have done to each other as execs. He brought that slightly outsider's view, but yet the outsider's view from somebody who understands what it is we're trying to achieve.
It's also about asking the right questions, the basic questions, How does this benefit the patient? It's the number one. And number two is, how does it save us money? And can you demonstrate that? We wanted evidence.
The board were very good at making the team feel personally accountable for whether or not the project was going to be a success. So we had to scrutinise all the assumptions in the business case, take them through our financial colleagues, make sure that everybody agreed with the figures that we were projecting.
When the caseload numbers were not as high as they had anticipated, there was a certain amount of pressure exerted to the senior management, and we actually got some community matrons from across the organisation to come and actually help to increase the level of assessments that we could achieve.
The board were also very helpful in terms of being clear that while they had high expectations of what we could deliver, that they were there to help us.
My role was very much to ensure that if there were any blockages in the system, that we unblocked them, and to give the staff the self-confidence and the assurance that they could make the changes which were necessary.
About 16 months since you've been... I think the board offered to unblock certainly when we were having difficulty with some of the GPs. In the end, we didn't need that extra support, but it was there if we required it.
Rolling it out did meet some resistance, and that's where I think the financial board needed to come in and say, no, this is the future, this is the way we're commissioning, and giving a tone which said, we're going to make change for the better here.
In terms of the lessons that we've learned, I think, from the pilot services and now the fully commissioned service, is that it's possible to develop an operating framework that everyone feels happy with and signed up to. What's difficult is staying true to that operating framework and delivering the service in such a manner as to achieve the outcomes, and that's about getting the throughput of patients, keeping the service dynamic and active and not allowing it to become a sort of static intensive care virtual ward, keeping it as a virtual ward that admits patients, assesses them, reviews them, cares for them, rather than admitting them onto the ward and looking after them for the rest of their lives, which is always the risk, I think.
I mean, the big prize in this, as I saw it, was that we would reduce the need for hospital beds. Therefore, we should have perhaps pursued more rigorously how we were going to extract those beds from the acute sector. It's easily said, was very difficult to do at the beginning because it wasn't proven.
And I think that's where the risk has been for the board, is that because it's a longer term project, how do you assess in the short term whether or not it's effective or not? Because you've got people with long-term conditions who will continue to deteriorate, and how do you kind of qualify that the virtual ward has had an impact on that?
One of the things that the board was good at was helping us to realise that if we wanted to see the number of patients that we felt we should in order to make savings, we had to break down the number of patients we were assessing in any given month. And working with healthcare at home was very helpful because they had the clinical credibility to be able to show our staff how to do that, and that proved to be very effective.
We had the ability to be the eyes and ears of the commissioners in terms of reporting to them how the development of the programme was going, and crucially around developing a performance management framework so that they could see throughout the development programme and the ongoing service delivery what the performance of the service was. We should have 4 patients a year. Yes.
We've got information that shows that patients who are part of the virtual ward have less hospital admissions. So it's doing what it's supposed to do from that perspective. From a personal perspective, having visited some of the patients on the virtual ward, it's really rewarding to see that it does for them what we hoped it would do for them in terms of them being able to stay at home, feeling they're managing their own conditions, having some authority over what's happening to their lives, rather than feeling that they're being done to by the system. They're taking some control of their conditions.
Yes, what you're doing with it all. Oh yeah. Yeah.
We're evaluating the success obviously through some of the key performance indicators and some of the cost analysis, patient satisfaction questionnaires, also through the GPs, getting some feedback from them as well.
Our anecdotal experience is that many patients, for example, with chronic heart failure and COPD, have actually been prevented admission quite appropriately on many occasions, and certainly patients that had been admitted previously 3 or 4 times over any given winter have actually had quite considerable lengths of time where they've not required hospital admission.
We've got figures now from our first projects that show that it's really significant. We're talking about a reduction of over half of what we would have expected. So if we hadn't intervened with these individuals, they would have been in hospital twice as much as they have been. And that is a huge change.
We send out questionnaires at 12 weeks, and the feedback that we've had has been very positive. About 93% of the patients have said they feel more able to manage their medication. 71% feel that they are more able to care for themselves now. And about 69% have said they feel that it's reduced their risk of going into hospital.
And it's nice if I do have a worry, there's a phone number over there. I think it saved us a lot of hospital visits, I think it does. I mean, we was backwards and forwards to hospital the 12 months before on a regular basis, but now we've had 12 months of no visits at all.
Right, thank you.
See what it is today.
The virtual ward team has managed to keep her out of hospital for 16 months, which has never happened for years. And keeping her out for 16 months has made a big difference to our lives.
I think it's a good scheme. It saved me going into hospital. I'm sure it has. And I think if it can be extended, it would be a good idea.
The virtual ward is something I believed in right from the beginning, and to be able to implement it with all the support locally has been fantastic. It works for patients, it gives great job satisfaction, and to be able to develop the service and increase the capacity has been fantastic. It's been a wonderful opportunity.
I think the virtual ward scheme has the potential to revolutionise the care of patients with very complex long-term conditions in the UK. I think it can be used to care for those patients at the very highest predicted risk of need and the highest cost, but I think the concept could be used for patients with a whole range of different levels of acuity.
Well, if I were a patient, I think I'd be amazed that the NHS had picked up the phone before I was ill and contacted me. It is something that's totally unique.
All the evidence we have from patients indicates that it's something they value very much and it's successful. And so from our perspective, that is a great achievement.